And now, Doc Talk, brought to you by Plateau Medical Center. Here's Dr. Paul Conley.
Good evening. Thank you for tuning in to another episode of Doc Talk. I'm Dr. Paul Conley. This is February, which is Heart Awareness Month or Heart Healthy Month. So we're going to be talking a little bit about heart awareness. Coronary disease is still the #1 killer of Americans in this country, for men and women. It actually kills more Americans each year than all colon cancer, breast cancer, and lung cancers combined. We actually had 841,000 Americans die last year from coronary disease. Tonight we got a couple guest lecturers here that are going to give us some insight about heart disease. One to my left, we have Dr. Clinton Curtis, who's our ER director here at Plateau Medical Center. Thanks for coming. And next to Dr. Curtis is Dr. Ely Garib. Dr. Garib is actually the Chief Staff Medical Director of the Cardiology Division at Charleston Area Medical Center. Thanks for coming tonight, guys.
Thank you for having us.
So basically, I think, what I want to talk a little bit about is heart disease. I think, we all see heart disease. It's something, again, it's the #1 killer in the country. And I think, one of the take-home points is that you don't have to be an older individual to have heart disease with a lot of the risk factors that we see. We're seeing that even in younger individuals. And I know, one of the things that, we see in primary care and we think about is hypertension. And I know in the country and in West Virginia, over 50% of people that have high blood pressure, it's not well controlled. So I guess maybe, Dr. Green, maybe you can talk at first a little bit about some of the risk factors, and then Dr. Curtis as well, about things that we see in the community that increases one's risk for heart disease.
Sure, and again, this is Heart Month, so it's a good topic to be discussing. The major risk factors for coronary artery disease, which again is the #1 killer in both men and women in the world, not only in this country, you have multiple risk factors. The first one you can't control. It's your genetic makeup. It's what you were born into. Genes do play a big part into causing heart disease. But then there's many other modifiable risk factors. Tobacco is one of the most common causes. And again, unfortunately, in our state, there's a lot of tobacco use, whether it's chewing tobacco or smoking. The other thing is diabetes, particularly with childhood obesity increasing and inactivity increasing. Diabetes is actually on the rise. And that's one of the major contributors to heart disease. One of the ones you mentioned is high blood pressure. That's also a big player. And high cholesterol. So these are the 5 main risk factors. And then you have other minor risk factors, as in obesity in general, inactivity. All of these are big contributors to heart disease. And that is why we are seeing younger and younger patients with this condition.
It was curious, you bring up some of those points. And when we talk about, just to give you some statistics, I was kind of reviewing some of these things. Smoking. 37 million Americans smoke. 37 million. When you talk about obesity, currently have 1 in 3 Americans are considered obese, and 1 in 6 children are now considered obese. And I think, we think about that. All you got to do is go to the local grocery store and you look at, what these people are buying and consuming. And I know, the things that we eat, high fructose corn syrup and sugary drinks, sodas. But like the sedentary lifestyle, I think that's changed too. When I was a kid growing up, you're always outside running around playing wiffle ball, whatever. But statistically, sedentary lifestyle, 1 in 5 of us Americans get the physical activity per guidelines, which is 150 minutes of moderate exercise, and only 1 in 5 of us are actually doing that. So, we definitely are seeing, a trend with all these things, which obviously is still the reason why it's the #1 killer. So I guess, Dr. Kurtz, tell us, with you working here in the community here in Oak Hill, tell us, how heart disease is important, to the community here in Oak Hill.
Well, we've already emphasized that it's the #1 killer, and really the incidence within this country is high, but really the incidence within our community is even higher. And in Fayette County, you're talking about deaths per 100,000, between 350 and 400 deaths per 100,000, when the national average is around 250. So we see a greater incidence. And that spans, just like we said, men, women. It's not isolated to one particular population.
So I think, from what you're saying, is it's not only it's a national problem, but obviously is a West Virginia, central West Virginia problem, and probably more so a central West Virginia problem than even on the national level.
Yeah, correct.
Unfortunately, it seems like every time I see a statistic when it comes to West Virginia, we're always like top of the list when it comes to obesity and heart disease and diabetes and dyslipidemia and smoking and teenage smoking. It seems like we're always on the top of that list. So I guess, Dr. Curtis, with you being in the emergency room and someone presents with, chest pain, or what are things that you're concerned about or worried about that would be symptoms of possibly someone having a coronary event or what we call an MI or heart attack?
Well, that's a complicated question, but the classic symptoms, the ones that most of us are more familiar with, substernal chest pain, radiation to the arm or the jaw, shortness of breath, nausea, breaking out into a sweat. Those patients present to the emergency department and are evaluated for cardiac disease. But there are a lot of atypical presentations that don't fit that mold. You can have isolated shortness of breath. 1 in 5 patients present to the emergency department with an acute heart attack and have no pain whatsoever. So they may present just with nausea. They may present with shortness of breath and isolation, that type of thing. So we in the emergency department are looking, because cardiac disease is so common, we're looking at most complaints and evaluating them for whether this is potentially a cardiac event.
So Dr. Gree, being a cardiologist, we were talking about, even before the show, a little bit about one, I think, again, it's like Go Red Month, and women, I think, again, women have, this misconception that, that's a male-dominant disease, but again, it's the number one, killing women as well. So women, diabetes, I mean, do these people, like Dr. Curtis said, some of the symptoms, do they present possibly differently than men, or does it make a difference?
It does. So let me address diabetes first. Diabetes is probably the most common contributor for very atypical presentation. And the patient may have what we call silent ischemia, not have any of the typical symptoms you are thinking about, but yet they're having a myocardial infarction or a heart attack. Women presentation are also somewhat different than men. Sometimes the heart attack symptoms can be just acute shortness of breath, fatigue of unknown etiology that suddenly occurs, feeling like they're going to pass out. It can be a shoulder pain or a jaw pain or a jaw ache. I don't even like, when I'm discussing with patients, I don't even use the word pain, because everybody's definition is different. Let's say a discomfort. What kind of a discomfort are you having, if any? These are the things you want to be listening to, because it's not always, sometimes it can be just a left arm ache or a jaw ache or a neck ache, or between the shoulder blade discomfort, or just nausea. Sometimes they feel that they have a toothache when it's really cardiac in nature. So you gotta pay attention to what these patients are presented with. Obviously, particularly if they come to the emergency room with these symptoms, they're feeling something a lot more than what they're telling you. They wouldn't have otherwise showed up.
Are there certain symptoms that would, in your mind, kind of seem atypical or less likely? Is it like the duration of the pain or the sharpness of the pain? Is there something that maybe say this doesn't seem cardiac to you? Or about some of those symptoms?
There is, a lot of other symptoms, obviously, that have nothing to do with cardiac etiology in nature. But you just need to be on the outlook for it. I'm not saying every toothache or every single patient that presents with shortness of breath is having a cardiac event. But what I'm saying is you need to look specifically for that, particularly in our patient population. And yes, if it happened acutely, if somebody has been telling you I've been short of breath for the past month, that's different than someone says, I was doing fine, and then I was walking up the stairs, and suddenly I became so short of breath I couldn't continue. That's a major difference as opposed to someone saying, yeah, I've been short of breath for a month, and I've been coughing my head off, or that's very atypical. But again, you just got to take a look at the presentation, the onset, what was the patient doing when that came on, particularly if they're doing physical activity or under a significant amount of stress or things of that nature. And then, you got to monitor other things once the patient presents, EKGs and blood work and what have you.
I'm sure, again, you folks take a risk stratification as well. I mean, I'm sure it's more concerning if you have a 70-year-old smoker who's obese, who has hypertension, has family history that maybe presents with some of these symptoms. So I'm sure you do a scoring system, when that patient presents. Looks like we're about ready to take a commercial break. And in saying that, when we come back, I want to talk to you, Dr. Kurtz, a little bit about how you score these patients when they come to the emergency room. And then I want to talk to you a little bit, Dr. Grieb, about our new affiliation with Plateau Health and CMC.
Plateau Medical Group welcomes Dr. Yancey Short to the Plateau Health Network. Dr. Short, a board-certified general surgeon, performs minimally invasive, laparoscopic, robotic-assisted, and traditional surgery. His care ranges from hernia repair, screening colonoscopy, vasectomy, and skin lesion removal. Dr. Short sees patients at 2 convenient locations: West Maple Avenue in Fayetteville and George Street in Beckley. Call our office today or request an appointment online at plateaugeneralsurgery.com.
And now we return to Doc Talk, brought to you by Plateau Medical Center. Here's Dr. Paul Conley.
Welcome back to Doc Talk. So earlier we were talking a little bit about with Dr. Grieb and Dr. Kurtz, a little bit about some of the symptoms of heart disease and also some of the risk factors. But now I want to turn over to you, Dr. Kurtz. So we went over some of the symptoms and the risk factors. So if an individual has these risk factors, they're having some of the symptoms Dr. Grieb was talking about, they realize this could be a heart attack or ischemia, okay, something in that nature. They present to Plateau Health. They present to your emergency room. How do you and your team here at Plateau Health work that patient up and triage them?
Yeah, well, first of all, what I'd say is if someone has the symptoms that Dr. Grieb was talking about, they shouldn't wait. They should call 911, get to the emergency department. If they're not allergic, take an aspirin. And then once they come to us, we start our triage process. And in our triage process, that patient comes in, signs in, gives their complaint, say it's chest pain or one of those other symptoms. Then the first thing we do is we're gonna have an EKG performed within 10 minutes or less. Usually that physician's coming in to see that patient at that same exact time, and then we're looking to an EKG to sort of help us make those initial decisions. Some of these EKGs will require urgent decisions and even transfer arrangements, this type of thing. Somebody's having an MI that's called a STEMI. And then others will continue, we'll draw lab work, that type of thing, to further assess the patient. Sometimes patients present, most of the time patients present, they have symptoms and their EKG is normal or not necessarily suggestive that there's an acute heart attack or something along those lines. What we do with those patients is we then gather more information. We get the lab work. We still treat them with a high index of suspicion that this is a heart attack or a cardiac event. And then we sort of look at their lab work, the history and this type of thing, and we formulate sort of a triage score. And the triage score that we use is the heart score. So are their symptoms suspicious? They're given points based on certain criteria that we use in a heart score. EKG being abnormal, whether some of their blood enzymes, particularly cardiac troponin, is elevated, this type of thing. And where they fall with respect to their heart score, sort of, we're able to risk stratify. So if they have a low heart score and considered low risk, they have a medium heart score, medium risk, and high risk, which usually indicates that that patient's going to be moving on to a tertiary care facility, that type of thing. And we have an affiliation with CAMC as well. And at that point, when we have this patient, we have the heart score, we're usually going to be touching base with cardiology or someone to make a decision as to what it is we're going to do exactly. So if we've got a patient that's low risk, we're going to talk to Dr. Garib and figure out what our next steps are.
So yeah, I think, you know, I'm glad that you point that out, that, you know, if you have symptoms, you know, make sure, again, you present early. I think we've all seen, you know, these folks who present to the office a week or two later and they got ejection fraction of 25-30% in their forward heart failure, and they had their MI 2 weeks ago and they thought it was a GI bug and the presentation was nausea because they got overheated in the cornfield, but in actuality they were having a heart attack. So I do think, you know, folks watching the show, you know, please make sure that you know, we address this early, because as they say, time is myocardium, and so we need to have this addressed, you know, earlier. The earlier the better. So in saying that, you know, so now you've done the heart score, you've evaluated the patient, Dr. Curtis, in the ER over here at Plateau, and you've determined that this is someone that, you know, maybe shouldn't go home and may need a further evaluation. So tell me, you know, how that works when you contact Dr. Garib or with Charleston, the telecardiologist. Tell me how that comes into play.
So most of the time, the people that we are going to make touch base with the cardiology are those people actually that are the low and middle risk patients. Because in the high risk patient, we're already making transfer arrangements, okay? And so we're moving towards, we already know what the decision tree is going to be. That patient's going to be moving on.
So at high risk, would that be someone that's actively having a heart attack at the time?
That's correct. Or is having unstable angina, meaning that they're in a state where there's decreased blood flow to the heart, that their heart muscle is at risk of damage. So those patients, we typically move to transfer from Plateau at that point. When we have somebody that's lower or a more middle, moderate risk heart score, then we're going to consult to determine whether or not what the next steps really are in that patient's care.
So Dr. Garib, so Dr. Curtis gets in touch with you and has that patient with that low to moderate risk. Tell me what you do on your end in Charleston and how you can help with the patient here.
Right. So, you know, if a patient is low risk, we discuss it over the phone and we make a determination just based that they are low risk, that they can be discharged home from the emergency room with a close follow-up. And, you know, some of that close follow-up can be done by our physicians that are coming up here. What we're really trying to do is to keep the patients where they're at as much as we can, so they don't have to do the traveling. So the patient is a low risk and they can be seen within the next couple weeks or couple days or what have you. We discharge them from the emergency room based on the heart score. If the patient is a medium risk, what we're trying to do now is to say, okay, go ahead and admit the patient to Plateau. And we will trend and check their blood work, make sure they are still not having a heart attack. And if all of the above is negative, more times than not, these patients will either get a stress test or sometimes what we call a CTA, that's a coronary CT, where we'll be able to basically look at their arteries of the heart through the CAT scan with dye to determine whether there's significant blockages or not. The patients who are high risk score, these are the patients that are getting transfers. And what we're trying to do with our affiliation is to make it simple for the highest risk to the lowest risk, for Plateau to be in touch with a cardiologist, and some of these we can do through telemedicine, particularly the patients are admitted to the hospital. We can actually physically see the patient through a screen and evaluate them based on their EKGs, their blood work, what have you. We also have the capacity now to be able to look at their CAT scan over in Charleston. We have the capacity to look at their echo, the ultrasound of the heart, their EKGs, any testing they have done, including stress testing, that we can see it as we would see it on our own screen at Charleston Area Medical Center. So we're able to keep the patients that don't need to be transferred out here at Plateau. And again, that's will help hopefully the patient not having to do the traveling, which is sometimes difficult for the elderly patients to go 1 hour, 1.5 hours away to seek medical care. We still want the highest risk patient obviously to be transferred out because that's where they're going to be served best.
So I think what that means for us in the community is that you have patients that are here locally that, again, like you said, may have issues with family with transportation. Obviously they're going to be transferred in an ambulance, but maybe a hardship getting the family and stuff there. So basically you and Dr. Curtis, at the time that the patient's in the emergency room, all of this is kind of going on behind the scenes, and then from what I gather, you two will be having a discussion, a conversation about how best to treat the patient, whether they can, again, either be discharged home or actually be admitted to the hospital. So if the patient, again, is admitted to the hospital, that's something that you can actually, the hospital service typically is who would admit the patient. So the hospital service can then get in touch with you with this telemedicine, and you can actually be, I guess, consulted to evaluate the patient?
Yes. I mean, the technology is so amazing that we can, from Charleston, listen to the patient's heart sounds, listen to their lungs, physically look at the patient, take a look at all of their lab work, all of the data that you have available is available to us on our own screen. And that's the beauty of telemedicine right now, which is really kind of expanding across the country because of that, where, again, the patient don't have to do the traveling and don't have to be transferred out of their community.
So, Dr. Curtis, as far as the telemedicine in the ER, I guess that would help you quite a bit at that point to determine whether or not to even make the phone call to our hospital service versus then making the transfer to Charleston. So has that helped you out quite a bit with the emergency room?
That's correct. Yeah, so we're actually, what's going on behind the scenes, we see the patient and we're actually able to consult with cardiology, look at the risk factors, and then be making the next steps in the patient's care much faster in this manner than would previously have been done. And the connection, even technology-wise, with telemedicine is nice too, because you can have someone look at see what we're seeing, see the EKG, the lab work, the echocardiograms, that type of thing, in real time and in the same quality as if the cardiologist is there with us.
So again, I mean, time is of the essence, and so I think the quicker that information is then sent to the receiving facility, then that data is received. If there's any medical management that can be done here, at Plateau, even if we're the patient's being transferred, that whole treatment, that whole modality can be started at that time.
Yeah, that's correct.
So we're getting ready to take another break. We've talked quite a bit about the different causes of heart disease, and we've talked about how we work that patient up. I think after we take a break, we're going to talk a little bit more about this affiliation and what that means for us here as physicians here at Plateau and the community when we come back. This is Dr. Paul Conley. You've been watching Doc Talk.
At Plateau Medical Center, we have the newest technology, which is robotic surgery. Prior to us getting it, you would have to travel out of the area into a larger hospital. By using the robot, less pain, quicker recovery time, quicker return to normal activities, and shorter hospital stays.
This new robotic platform allows us to do what we do and do it even better, and that's only going to benefit our patients.
It's not about the technology, it's not about the robot, it's about patient outcomes.
And now, back to Doc Talk, brought to you by Plateau Medical Center. Here's Dr. Paul Conley.
Welcome back to Doc Talk. I'm Dr. Paul Conley. Tonight again we have Dr. Clinton Curtis and Dr. Ely Garib. We've been talking about heart awareness and heart disease, especially the month of February, the Heart Awareness Month. And so we've been talking a little bit about heart disease, and we've been talking a little bit about the presentation. But we're going to talk a little bit now. We're going to shift gears just a little bit. We're going to talk a little bit about the fact that we have this new affiliation with Plateau Health and Charleston Area Medical Center. So, Dr. Garib, tell me a little bit about CMC. It's obviously well known throughout the state, and it's a teaching program. So maybe you can talk a little bit about what the value is of having, us here at Plateau Health and associated with Charleston Medical Center.
Well, thank you for that question. I mean, I'm passionate about this. This is it's really a great time for us. What we have done over the past several years at CAMC, we've really built a very nice cardiac center across, and we're going to many different areas. First of all, we have the teaching program that started about 2 or 3 years ago, and we have our batch of fellows coming up, which is kind of nice. We have many different subspecialties within cardiology that has developed. We have a congestive heart failure clinic, and we have structural heart. These are the people that would need valve replacement without basically opening up the chest. We have different devices for atrial fibrillation called the Watchman for patients who cannot be on chronic blood thinners. We have ways to treat mitral valve disease without opening up the chest. But we still have all the expertise when it comes to cardiovascular surgery. We have top-of-the-line surgeons that work with us. And now what we're bringing into, which is coming up next, which we're really excited about, is imaging. And we really have world experts in imaging, in cardiac imaging, whether it's MRI, whether it is CT scan, whether it is nuclear stress testing. We have the biggest experts really coming to us that will be teaching our fellows. And with them, with that, we are able to take a look at the images that are being done at Plateau and be interpreted by our experts in Charleston. And it will be like a live look. They'll be able to see it as soon as the CAT scan's done and can give the results to the physicians here at Plateau. So our objective is to provide the most support for this community. At the same time, the patients that can stay here, they don't have to be transferred elsewhere. But if they need to be transferred, we want to make sure that we provide the best service for them, the most comprehensive service available.
It's amazing, talking about, just TAVR, the trans-aortic valve replacement. When I was in medical school in the 90s, we always talked about, the angina, syncope, heart failure, and this, and once you get to heart failure, life expectancy was short. But these patients, a lot of times, just, had so many comorbidities that they never made it, to the operating room. And now, you folks are able to do that basically through the guide wire, through the groin, and are able to basically take care of that patient, like you said, without undoing, or as I say, unzipping the chest, the things that are available. And, I think, this team approach that Dr. Curtis, we're talking about, I always thought, it's in healthcare and medicine, it's better to have a bigger tent than a smaller tent. And I think this tent hopefully is encompassing, so many individuals, throughout our community, here not only in Fayette County, but I know we see patients, from multiple counties, which then can receive their care here. So I think, one of the things that, I think it's just, like you said, it's a connection that's closer to home. And so you're receiving, big city medicine, with hometown care. And I think that's, I think is real special about this affiliation. So I guess, we only have a couple minutes left here before we wrap up. I just want to talk a little bit about, so the patient has, underwent the evaluation, they've been seen, they've been evaluated by you, Dr. Garib, and Charleston. And so they've maybe had intervention, maybe they've had a stent, maybe they've had bypass surgery. I think it's important for the folks to know watching the show that, then, at that point, the patient then, can follow back up with their local physician here. And as far as that goes, the information, how does that then, get transferred or sent back to the local providers and the local physicians, or does it go to the local physician? So then they have some follow-up as well, passing that baton back to the provider.
Yeah, it actually does, and that is one of the most crucial points that we can do, is to make sure, and that's the first thing I do as soon as I'm done with a procedure, is send a copy to the primary care provider with my plans and what I would like to do for that particular patient. And our surgeons do the same thing, and our hospitals do the same thing. We always send a copy of what we have done, because we understand and we realize that some of these patients live 1 and 2 and 3 hours away, and they may not be coming to Charleston as often as someone that's local. And so it's very important to relay that message to the primary care provider, and particularly like patients who end up with a heart disease of any form, they need to have cardiac rehabilitation, and that's important to have it at a local level, because there's a lot of education and a lot of prevention. The biggest problem with having a heart attack is your likelihood of having another one is extremely high. So that's the reason why we need to do our best to prevent, to lower their cholesterol to the lowest level possible, to make sure their blood pressure is at optimal level, to make sure they quit all tobacco products. And this is where cardiac rehab really plays a big part. Make sure the diabetes is controlled, so they don't have to come back to the emergency room in 2 or 3 weeks or 2 or 3 years.
And I think that's that continuity, again, like you said, because we talk about primary prevention, I think we see so much of secondary prevention and how we prevent that second heart attack or going back to the cath lab or back to the operating room second time. So Dr. Kurtz, we're getting ready to finish up. So any final thoughts about patients out there and how they can reduce the risk of heart disease?
Yeah, well, obviously we're happy to have a net for patients to, and a pathway for patients to sort of get their care established with cardiology. They come to the ER, we make that connection. They come back into the community and are treated. But really we'd like to see them never have to come to the emergency department to begin with. And there's some estimates that really 80% or so of cardiac disease is in some way preventable. We talked about sort of the non-modifiable risk factors, but there's a lot of risk factors that can be modified. And I mean, smoking cessation, stop smoking, that's first and foremost. After that, a lot of things can be altered through a dietary intervention, dietary changes. And so really talking with your primary care physician or getting that sort of information on once you've stopped smoking, you want to alter your diet, all those things, this is vital to preventing that first emergency department visit and subsequent ones too, in those patients who have established heart disease.
Well, I really appreciate you guys coming in tonight. I mean, you guys have a wealth of information. Between the two of you have 50 years of experience, and I really appreciate Dr. Grebe, Dr. Curtis. For those watching this show, this has been another episode of Doc Talk. I'm Dr. Paul Conley, and until next time, good night.